Hi there, my name is Colin Brown. I'm an infectious disease consultant based at the United Kingdom Health Security Agency. I'm Deputy Director of Clinical and Emerging Infections with responsibility for antimicrobial resistance. I also direct UKHSA's WHO Collaborating Centre for Reference and Research on AMR and healthcare-associated infections, and I'm the UKHSA lead for a Health Protection Research Unit alongside Imperial College, funded by the National Institutes of Health Research, again on healthcare-associated infection and AMR. In this brief slide set, I'm going to hopefully help you understand the role of the UK National Action Plan, or otherwise known as the UK NAP for antimicrobial resistance, and UKHSA's activity within it. Understand some progress made towards targets in the 2019 to 2024 NAP and those underpinning those in the 2024 to 2029 NAP, and understand digital health solutions from an AMR perspective that underpin our surveillance activities. I've suggested here some pre-reading, essentially the National Action Plan that has just finished from 2019 to 2024 and that which has just started from 2024 to 2029. Many of the lectures will recap all of this, so I won't go into too much detail, but just to highlight that AMR is a global burden requiring urgent action from policymakers and the healthcare community. If we look at the overall burden of disease that has been suggested to be associated with AMR, then currently it is greater in 2019 deaths than those attributable to HIV/AIDS, breast cancer, and malaria. And if we look at projections by 2050, this is in the Lancet Committee, over 10 million people are going to die each year due to antimicrobial resistant infections. The cumulative cost of that will be up to $100 trillion per year. And if we look at more recent UK estimates, 774 million is estimated to be the total annual cost of healthcare associated infections, including bed day costs in the UK. That was in the year 2018 to 2019. So combined antimicrobial resistance and also healthcare-associated infections intertwined are an incredible amount of resource and morbidity and mortality for this country and globally. If we look a bit on the UK's individual AMR burden, it is captured in the National Risk Register, costs the NHS about £95 million per year. And in England, 19 out of 100 people with a key pathogen bloodstream infection had a resistant infection in 2021. Resistance is increasing and creating a new generation of superbugs that cannot be treated with existing medicines. And this is a quote I get from one of our recent reports. Antimicrobial resistance is not a distant problem that we can ignore. Infections caused by antibiotic-resistant bacteria are killing thousands of people every year in this country and globally, as well as having a huge economic impact. So it's very clear that there is an imperative to act now on redressing the challenge of AMR. I just wanted to highlight that it is one of UKHSA's core priorities. UKHSA is the national public health agency within England, with some cross-UK responsibility. And we have several of our main priorities here: being ready and able to respond to all hazards to health, improving health outcomes through vaccination, protecting health from threats in the environment, improving action on health security through data and insight, and developing UKHSA as a high-performing agency. But then core among that is reducing the impact of infectious disease and specifically antimicrobial resistance. So AMR is a very key part, integral to all of UKHSA activity. So I'd like to go over now the evolution of the UK's response to antimicrobial resistance. In 2011, Sally Davies, when she was Chief Medical Officer, focused her annual medical report on the burden of antimicrobial resistance. In 2013, we then published the first in our 5-year plans. This was the precursor to the National Action Plan, with an AMR strategy lasting up to 2018. There were a couple of important things that happened in 2016. First, the O'Neill report, a UK government report into the state of antimicrobial resistance worldwide. And then the UN General Assembly held a special meeting on AMR where they published the ad hoc interagency regulatory framework with a coordination group about how to monitor cross-specialization threats for One Health for AMR. Then in 2019, we launched two things. We first of all launched a 20-year strategy to look at the vision that we would have using surveillance, research, awareness, and education activities underpinned by regulation, investment and advocacy, and building on the achievements in the 2013 to 2018 plan, that over the next 20 odd years, by 2040, we would fulfill 9 ambitions. 1 was to being a good global partner, 2 was to drive innovation, 3 was to minimize infection, 4 was to provide safe and effective care for patients, 5 was to protect animal health and welfare, 6 was to minimize environmental spread of AMR, 7 was to support sustainable supply and action and access to medicines, 8 was to demonstrate the appropriate use of antimicrobials, and 9 was to engage the public on AMR. We also launched our first proper 5-year National Action Plan at the time for 2019 to 2024. And then over the last 2 years, we have developed the upcoming 2024 to 2029 strategy. So essentially, this 20-year framework looks at AMR requiring complex long-term action, with progressively strengthening our AMR understanding and our understanding of what works to control and contain it. The 5-year National Action Plans will support this vision, and they will prioritize actions and direct resources based on the latest available evidence regarding the biggest risks and the interventions available to tackle them. They will be impact-focused, understanding the effectiveness of interventions, and focusing on areas that offer value for money and a real opportunity to make impact. They will be stepwise, using surveillance data in particular and research to evaluate the risks, monitor trends over time, and understand what works to prevent and slow the spread of AMR. They will be evidence-based, establishing a robust evidence and building predictive models that allow us to develop the right tools to have effective interventions. They will be flexible, using emerging information to guide investment decisions and set delivery timescales, and remaining open to changes based on the latest available evidence. And they'll be responsive, learning from others, learning from past national action plans, including from fields with established knowledge and expertise, and from other countries' good practice. And they will be harmonized, collaborating across the sectors and groups, both professionals, public, and patients in the UK and wider, aligning with relevant global initiatives. The key themes for the 2019 to 2024 NAP were to reduce the need for an unintentional exposure to antimicrobials, optimizing the best use for antimicrobials in different environments, and investing in innovation, supply and access. And then the current NAP that we've developed builds on all of this experiential learning. So if I focus in on the last 5 years and what our ambitions were, we unfortunately are not quite in a position to say exactly how we've met or not met all of these, but I'll give some suggestions. So on the right-hand side here, we look at the content areas. So we again, key themes of reducing the need for unintended exposure, optimizing use of antimicrobials, and investing in innovation, supply and access. And if you want to look in a bit more detail under these, both you can read the action plan or look in more detail on the slide, with various levers and enablers along the way for us to achieve these ambitions. The 5 ambitions that we had were to reduce a specified set of drug-resistant infections by 10% by 2025, to reduce healthcare-associated gram-negative bloodstream infections, those are the type of bacteria that live in our gut, by 25% against the 2016 baseline up to 2022, and then by 50% up to 2024. To reduce the UK antimicrobial use in humans by 15%, to provide a 25% reduction in antibiotic use in the community from the 2013 baseline, and provide a 10% reduction in the use of reserve and watch antibiotics in hospitals from the 2017 baseline. Those are antibiotics where we're most concerned about their use because they're broad spectrum and are sort of our antibiotics of last resort. So did we meet all of these? Well, not quite. Some of them we came very, very close to, particularly our ambitions around antimicrobial kind of usage, both in the community and in general, and our use of improvements towards limiting the amount of reserve and watch antibiotics. And then the drug-resistant infections and the healthcare-associated infections, particularly the very ambitious ones for 1B, about the 50% reduction, we have made a lot less limited progress towards, in recognition that these are very complex asks and that they are multifactorial in terms of how best to achieve our goals, and we didn't quite do that in the last 5-year National Action Plan. But we have learned an awful lot about what may work in terms of progressing with the next one, and it is clearly very complex. The COVID-19 pandemic also had an incredible impact on these ambitions. We reduced an awful lot of antimicrobial usage just by pure fact that many people were not going into hospital or healthcare facilities. And in some ways, some of the reductions in the resistant infections may also have been enabled by less complex procedures or people having delayed care. As the pandemic gradually became more manageable and healthcare services resumed, those trends have largely reversed, and I'll show some graphs later on that will highlight this. If we give one example, for example, of changing healthcare utilization, here is one research study that shows, if you see the line on the left-hand side in the white, what happened pre-pandemic, and then the trajectory, kind of what would have happened in being continued in the grey box, but what actually happened with the elevation being seen post-pandemic. And this was looking at healthcare telephone consultations and antibiotic prescribing based on whether you were seen face-to-face or over the telephone. And what it kind of showed was that there was an increased likelihood of being prescribed antibiotics if you had a phone or telehealth conversation than if you were seen face-to-face. Now, we should ideally be encouraging the use of telehealth. I think there are great digital advantages to access for this, but with recognition that where patients are not in front of you and you cannot examine them, and where you cannot do immediate diagnostic tests, there may come an increased likelihood of having an antibiotic prescribed. We also have new initiatives. So this is one online retailer offering treatment for urinary tract infections. And we now have Pharmacy First, which for 7 common conditions across the UK offers a direct port of call to pharmacy to allow for pharmacists to make algorithmic decisions about antibiotic prescribing. And I list there the list of syndromes such as sinusitis and urinary tract infections and impetigo. This clearly, again, has got an incredible benefit of widening access to a large group of patients and reducing the time needed for people to access care. However, we will keep under close observation what it will mean for antimicrobial prescribing in practice. And this is from our National Annual Report, the English Surveillance Programme for Antimicrobial Usage and Resistance, the EPSRC report. And it shows what I was saying in the last slide, basically. We saw a year-on-year improvement pre-COVID in antimicrobial prescribing. This is in primary care, but the same trend is seen in secondary care, where we had a year-on-year decrease. Then a big decrease due to COVID-19 pandemic, likely due to that change in healthcare utilization. And then an increase again with what is being seen post-pandemic. And the question will be, will that continue to increase or will that level off? And over the next number of years, we will be keeping this under close consideration. So based on our understanding of what happened in the last National Action Plan, we combined with Department of Health and Social Care, who led the development of the next National Action Plan, using a robust theory of change framework within a One Health approach, looking at animal health, environmental health, and human health all together. We co-developed some of the National Action Plan with UKHSA as a key partner within this, alongside NHS England and the devolved administrations. We led the development of the human health surveillance targets for this, producing recommendations for what we think appropriate and reasonable but suitably ambitious targets would be for the next National Action Plan. Into the relevant boards, and we led the development of new content areas for human health surveillance, particularly co-developed 3 areas about defining outcomes, defining high-level commitments, all with smart implementation plans attached. In developing these activities, we took a collaborative approach across the UK, looking at One Health as a key enabler, being a good global partner, trying to focus wherever possible on reducing inequalities, and providing resilience to a changing health threat landscape. We've got 9 strategic outcomes in this National Action Plan, underpinned by 30 commitments that set out the activity that government organisations will undertake to achieve the outcomes. We will be reducing the need for an unintentional exposure to antimicrobials, looking at infection prevention control, public health engagement and education, and strengthened surveillance. We'll be again optimizing the use of antimicrobials with antimicrobial stewardship and looking at how they are disposed of, and looking at the AMR workforce. Investing in innovation, supply and access with a key focus on innovation influence within the technology sector. Looking at information for action, so looking at data needs and how best we can present that back to decision makers. Looking at health inequalities, and again, AMR diplomacy, as evidenced by Sally Davies in her continued global AMR advocacy role for the UK as Special Envoy. A lot of this NAP focuses on the same areas that we have seen before, but there are some new and exciting commitments that mark a fresh approach to confronting AMR. Empowering the UK's human health, animal health and agriculture workforce, raising public awareness and understanding of AMR to empower citizens to effect behaviour change, supporting farmers to reduce the need for antibiotics in their animals through initiatives to reduce disease and improve animal health, improving the surveillance of infections and the implementation of effective infection prevention and control measures, collaborating across the public health sector with academia and the industry to overcome market barriers and bring new products to market, specifically new antimicrobials, but also diagnostics and digital platforms. Strengthening the understanding of the differential impact of infections across vulnerable groups, supporting clinicians, veterinarians and farmers to target antimicrobials only to those patients and animals that need them, expanding the NICE NHS England subscription model for antimicrobials, where we pay on bulk for access to novel antimicrobials in the hope that that will incentivize people to bring new products to market. Driving advocacy and engagement for international action with a focus on the upcoming UN high-level meeting for AMR in New York this September in 2024. And using a One Health integrated surveillance approach to inform effective interventions across sectors to reduce AMR's consequences. We recently launched PathSafe, which was a big food standards agency piece of work looking at the role of agri-food and our understanding of different food safety from an antimicrobial stewardship point of view, which also looked at environmental wastewater monitoring, for example, as a key piece towards this. And finally, looking at research, we've identified some key critical needs that we need to answer. What is the cost of AMR? What is the relationship between AMR and health disparities? How do we influence public awareness and behaviour on AMR? How do we be a good global partner in international settings? What are the basic drivers that affects AMR and how does it spread? How do we prevent it from spreading? How do we best optimize the use of antimicrobials? What methods can we use to prevent, treat and manage infections without the need for antimicrobial medicines such as antibiotics? And how do we bring innovation with new products for tackling AMR? And how can we ensure that what is known to work is implemented? And looking at what UKHSA aims to do within these is we aim to look at big data and novel ways to assess real-time threat detection. We aim to maximize our whole genome sequence capabilities, so we have more of a global understanding of what the genomic differences and similarities between bacteria are as they spread among the population. We aim to model and evaluate population-level health interventions, collecting data so that we can model how likely these are to be effective. A strong focus on infection prevention and control. Harnessing research into policy outputs and public health actions, ensuring that research on the last slide of those 10 questions is integral to all the work that we do, and embedding tackling health inequalities in all of our work. We also aim to improve novel drug surveillance, understand vaccine development needs as they relate to antimicrobial resistance, and focus on at-risk vulnerable groups to understand the prevalence and the population needs better within those areas. So if we look at the 30 commitments, I won't go into these in detail, but these just give an example of all the different commitments that are in the next National Action Plan. And you can see that UKHSA has got a wide range of deliverables that we both own and also ones that we are leading or helping collaborate on. So that gives a framework of where we are for the 2024 National Action Plan. There are very similar targets to what we had previously, focusing on antimicrobial usage and preventable hospital infections. For the first time is a focus on an ambition relating to understanding staff and public awareness about AMR, and particularly within England, we are focusing on embedding that inequalities work across every single bit that we do. So that's an introduction to the National Action Plan. I want to show now about what UKHSA activity from a digital point of view in particular is geared up to amending and informing those National Action Plans. So if we look at what is digital health for AMR, well, the SRC definition is that digital health research and innovation is comprised of challenge-led and user-led design, development and evaluation of novel digital solutions for wellness, prevention, diagnosis and treatment, including but not limited to digitized health systems and operational activities, the Internet of Things linked to sensors and devices, immersive technologies, AI-based decision support tools, health analytic tools, and digital social healthcare interventions. And I'll show how we have engaged with some of those over the years through our work in UKHSA. So first off, I just wanted to talk about mandatory surveillance. So we have a digital platform to capture all of the surveillance activities for healthcare-associated infection. Initially in the 1990s, it was voluntary. Then we started with MRSA being recommended for specific data collection in 2001. We increased the frequency to quarterly reporting in 2004 from annual, and then we increased it to monthly thereafter, and we added Clostridium difficile in 2007, and then we also included MSSA, so methicillin-sensitive Staph aureus, as well as MRSA. And then in 2013, we started collecting E. coli, so the first gram-negative through mandatory surveillance. And in 2017, we then added a variety of other program measurements, also defining where infections were healthcare onset related or community onset related. So this is the web tool interface, as you can see in the graphic, and it provides a comprehensive data collection form looking at patient demographics, specimen details, prior healthcare exposure, and risk factor data. And through this, we are able, in an integrated data way, to provide a number of routine outputs. So we can look at monthly the counts of cases, trust level, and also at an integrated care board level or sub-integrated care board level. We produce fingertips data, and up at the top is an example of the fingertips output, looking at antimicrobial usage and also resistant pathogens that you can peruse on an individual or not kind of individual primary care practice or hospital level to see what antimicrobial resistance patterns are and what antimicrobial usage there is. We produce regular fact sheets, quarterly epidemiological reports. We report into the National Action Plan and National Health Service for England progress boards. And then annually, we produce an annual epidemiological commentary. We produce independent sector reports. We produce an annual mortality commentary, at least we did up until last year. And then there's a variety of different kind of protocol and data outputs. And these are available, importantly, for researchers to be able to access where relevant. So integral to all of our surveillance is a digital data solution. Another example of this is looking at surgical site surveillance. So we have a national surveillance program established in 1997 to enable comparisons within and between healthcare facilities to facilitate improvements in patient care. And patients are followed up for 30 days after surgery. Then they do an online data form. And then we aggregate all data from across the contributing hospitals to provide individualized hospital reports, which benchmark where they are within comparator groups. We also do outlier analysis. So if there are people that we think are performing differently than what we might expect, we do more bespoke in detail analysis for those settings. And this is just looking at the number of infections that has happened across the various kind of years of the program activity in different surgeries. And you can see there is an increasing sort of downward trend in many of those infections, particularly orthopedic, but also somewhat in GI surgery and cardiothoracic surgery since implementation of this project. Looking at the work of our antimicrobial resistance and prescribing team, we integrate across a number of different data sources. So second generation surveillance system, which pulls positive microbiology data from across the NHS, linking to clinical data for hospital episode statistics, enhancing that with NHS batch tracing service data, looking at primary and secondary care prescribing, for example, data from the NHS, RxInfo and IQVIA, and then linking that to mortality data with particularly death registration. We can provide a wide variety of antimicrobial resistance and antimicrobial prescribing outputs into health protection reports, quarterly reports, the notification of infectious diseases, putting that information onto fingertips, pulling sequence data where hospitals assess their quality progress, and a variety of other kind of outputs that are listed here. Key to this year, for example, was doing a healthcare-associated infection and antimicrobial usage point prevalence survey. And we have also integrated all of our activity through WHO systems reporting into the WHO GLASS system, where we upload the UK's AMR data for international comparison. There's also a big amount of incident response work that goes on. This is a slide that just shows On the left-hand side, the beginning of an uptick in 2022, 2023 in the dark blue line, and then the kind of early bit of the graph in the kind of a budded line showing an increase early in the winter of 2020-22, which led to a big incident response for Group A strep and scarlet fever. And we were able to link up those national data sets, looking at prescribing from Boots, for example, looking at prescribing from respiratory antibiotic prescriptions and feeding into the national incident response and the incident management structures, looking at demand for respiratory infection-related antibiotics. Through that outbreak, we can also look at other digital data trends. So this is looking at Google searches in the UK for scarlet fever. You can see year on year some increase largely associated with the previous large waves that we'd had about 10 years ago. And then we suddenly see quite quiescent, and there was very little over the COVID pandemic, and then this big surge up in winter 2022, and that maps on exactly to what we saw with that peak that we saw in scarlet fever activity of winter 2022. And we're looking to see how we can integrate these public search data better into our systems. We also have a large AMR modelling and health economic component. So this is using our surveillance data to estimating disease burden to justify the level of investment and improve resource allocation, to both understanding the drivers and defining what we think likely interventions are, how they're going to work, and also to figure out the best design for rational decision making to reduce infections, and for predicting the future for AMR, also looking at what surveillance trend and analysis we're going to need in the future and highlighting uncertainties and how much they matter. These are some key outputs from some of those digital modelling sources. So we've looked at the global burden of antimicrobial resistance in that seminal 2019 report. We've also estimated the effect of healthcare-associated infections on increasing length of stay, looking at the economic cost for antimicrobial resistance and the impact of interventions, and estimating the burden kind of nationally and internationally of AMR, as well as looking at targeted areas, for example, on E. coli bacterias in England, and looking at what we think the economic and the healthcare burden are, all to build our understanding. In some of those slides that we showed previously for our antimicrobial resistance and prescribing team, they bring together a bunch of different data sources, and we have developed novel linkages using the unified infection data set, where we are looking at our research and surveillance needs, and we curate information by linking multiple data sets across one environment. And you create a primary data set, create a secondary data set, you merge them together, you apply case definitions. For example, how many bloodstream infections happen with strict, tight definitions of what those are. And then you can build up a workflow and answer various research questions. And that's really helped us in a wide variety of outputs. So we looked at hospital onset COVID-19 infection. We linked different COVID-19 data feeds to improve our reporting to NHS England. We looked at kind of different length of stay denominator data. We've integrated with different types of healthcare association data feeds. And we've done dynamic national trends of inpatient diagnoses. We've looked at multiple incident management response. And we've done various bits of ad hoc research with this ability now to integrate multiple data sets in one platform that you can specifically interrogate for research questions. We also want to look at big data trends for AMR. Now, this is looking at some of those other infections we talked about early on, the bloodstream infections for MSSA, MRSA, Klebsiella pneumoniae, Pseudomonas aeruginosa, E. coli, and also Clostridium difficile infection. So our mandatory organisms for reporting. And again, these trends show that some were decreasing, some were kind of more flat, interrupted over the COVID-19 period quite considerably. But a lot of the trend lines that we'd seen before now emerging once again, for example, for MRSA, MSSA, and indeed for things like Clostridium difficile, the increasing in a manner that we haven't seen for a number of years, largely likely reflecting the health system's pressure across the NHS post-COVID-19. But we want to bring together further big amounts of data with artificial intelligence tools and machine learning techniques so that we can better understand trend analysis. It's fine presenting this in granular detail. We want to dig further to be able to pick up what is happening in 18 to 25-year-olds in respiratory infections in the northeast of England, for example, and to really pick up emergent trends earlier on. This is a slide from some Imperial College colleagues with the Centre for Antimicrobial Optimization based at Imperial College, which we co-lead a health protection research unit on AMR on. And it's just showing the wealth of work that they have done, looking at how you can integrate novel data techniques into understanding what it means for patients. So you can look at the probability of an infection happening, your antimicrobial choice selection, the likelihood of a sample being resistant, determining the duration of therapy. And they've done a wide variety of different work, again, looking at merging novel data sources into the routine data collection for the healthcare environment to come up with these personalized outputs. We've done some digital engagement in a variety of settings. So we've got a couple here. We've got eBug, Target, and Antibiotic Guardian. eBug is a resource for children and young people, educators, and households to teach children about antimicrobial resistance. Target is looking at care workers, pharmacists, and general practitioners, teaching them about antimicrobial drugs and the best use thereof. And then Antibiotic Guardian combines these activities but goes further across a wide variety of One Health landscapes to encourage people to take advocacy about their own use of antimicrobials. I'll go into a little bit of detail for each of these. So eBug is just what I said, a learning environment for children as a health education program that promotes positive behavior change among children and young people to support infection prevention control efforts and to tackle AMR. It provides free resources for educators, community leaders, parents, and caregivers to educate young people aligned with early years and key stages 1 to 4 curriculum objectives in England. The Target Toolkit, this is just one example of the type of activity we do. So there's self-assessment toolkits for GPs and commissioners, various webinars and podcasts, interactive training tools, antibiotic and diagnostic quick reference guides, leaflets you can print out to discuss with patients, and audit and other antimicrobial stewardship toolkits. So again, a digital data hub that we provide with a variety of tools and resources. We've also done some novel things. This is looking at COVID-19 therapeutics, where we looked at in silico, in vitro, in vivo, and in population level approaches to the use of novel COVID-19 therapeutics. And some examples of data within that were structural modeling. We looked at what was happening to new variants of COVID and figured out whether we thought it was likely to have an impact on whether drugs would work or not. And then we followed that up with lab testing, genomic surveillance, linked in with epidemiology to determine whether we were seeing those in patient populations and what that meant for stewardship. And it was the intersection of a lot of different digital data sources that I think highlighted what we might be able to do for future antibiotics and novel antimicrobials going forward. We also did a lot of interactive surveillance work for COVID-19. This, for example, is looking on the left-hand side of different types of antimicrobial resistance, which you can see countries filled in about where they've got 2 different types of carbapenem-producing Enterobacteriaceae. The problem with that is it's a country-level approach. It is not very dynamic, so it doesn't tell you much about the sub-country level or where the real risk is from. We had much better trend for COVID-19 in a big UK dashboard, and the one down below is looking at Southeast Asian data coming out of University of Oxford, where again you can see the possibilities of much more granular detail, heat maps of countries, regions that are affected, cities within that, and it would give much more meaningful information on antimicrobial resistance to know which pockets of which countries is resistance coming from, and that would help with screening policies within hospitals, and again is something that we hope to develop more in the future. Engaging the public through a digital AMR approach. Again, looking at our health protection research units, there's a couple here from the University of Oxford and one from Imperial College, using citizen science approaches. On the one on the left, it's looking at whether by visualization, people can determine whether E. coli is susceptible or resistant to antibiotics. On the one on the right, there was a Bash the Bug campaign, which was helping TB diagnostics and looking about whether we could diagnose multi-resistant TB infections. And in the middle, Imperial College, where people were sent out kits to go and swab their home environment and determine if there were drug-resistant fungi there. So multiple approaches here that I think we really need to harness going forward about engaging the public in digital data approaches. Cancer Research UK, for example, have done a very good job looking at citizen science approaches to engaging the public on cancer data. And I think we need to be much better and bolder at doing that going forward. So here are some examples of engaging the public with different digital AMR approaches. So the 3 examples of citizen science projects from our Health Protection Research Unit's colleagues in University of Oxford and Imperial College London. On the left, we've got people through a digital app-based approach determining E. coli bacteria, whether they were susceptible or resistant. On the right, we've got something similar being trialled for looking at tuberculosis and multi-resistant TB. And in the middle, a different approach where people could sign up to get sent out a swab that they would swab their home environment to look for resistant fungi. And we need, I think, to be building on this considerably to look at the ways that we can engage the public going forward. Cancer Research UK have done a wide variety of citizen science-led data projects, including gamification of data, which I think have been really groundbreaking, and we could learn an awful lot from that going forward in antimicrobial resistance. We've got the SPAR report, as I mentioned before. So this is the one place that we bring together our antimicrobial usage, resistance, prescribing, and public and professional engagement activities. And it's a wealth of resources, and I would encourage people to look in detail at this year's one, which in particular is the 10-year anniversary since it was first launched. There's been a wide variety of publications arising from this that you could read more about. And again, there's graphs here, as we've seen the one on the top left before, looking at primary care, but it also gives us trends in resistance data and looking at prescribing data in secondary care at the bottom. So there's a wealth of infographics, and again, things that are available for people to integrate into talks or awareness campaigns. So I hope that that's given a broad flavour of both the development of the National Action Plan, where we've come from, the strategic approach, and some of the digital data tools that UKHSA has for our surveillance activities to be able to capture that data and present it in a meaningful way. I think there's a large number of outstanding requirements going forward that we still don't know the answers to. So we don't really know what the key drivers for AMR transmission are, and what data do we need to be able to determine that. Where we're talking about evaluations, what data do we need to prevent the introduction versus interrupting transmission? What data is best needed to determine whether we should be diagnosing infections right at the start or treating them as they arise, targeting community areas versus hospital areas, targeting antimicrobial usage versus antimicrobial resistance. For new digital software packages, like the really interesting ones developed through our Imperial College partners, how do we understand best their adoption? Where do they place themselves in the system? How do we integrate them within things like health technology assessments that evaluate their role within prevention of AMR and getting a cost attached to that so people can really see the impact? Trying to figure out which targets are self-fulfilling. Some of those that we had before may well have been happening already, like the trends in antimicrobial usage, or what really stimulates action, and how do we get data and digital reporting needs aligned with those. We need an expanded, educated digital workforce that's very literate in utilizing these new techniques. For example, artificial intelligence, better citizen science engagement. We need big data and AI for national surveillance and personalized approaches combined, and that's going to require a complete rethink about the way we structure our surveillance workforce. We need to really think about inclusion, health, and vulnerable groups. Both how can we use digital data for their benefit to identify the key needs, but avoid equity gaps where people don't have access, for example, smartphones. We need much more economic impact evaluation with modelling to inform the investment approach. Where we have, for example, novel technologies like point-of-care tests, we really want to encourage their use, but we want to ensure that we get that data back into the surveillance systems, and how best do we do that? And from the public, how do we go from that increasing awareness to getting them properly engaged in advocacy and campaigning and evaluation of data? So in conclusion, lots of great activities on the horizon, but we need ultimately harmonized global reporting systems across One Health, and there are big data challenges with that. We need data linkage across different environments, patient, hospital, community, wastewater, climate data, even looking at the interaction, for example, of high temperature on summer urinary tract infections, low temperature on winter respiratory tract infections. And that's going to require a massive data repository, the likes of which we haven't seen before. We need novel lab approaches with improved molecular diagnostics, combining different types of sequencing detection. And we need to integrate that data from both academic centres and public health centres. And we need to provide a data solution platform that will allow people to contribute all that data together that we can then make available to all to analyse. We need novel large-scale surveillance approaches, looking at, for example, wastewater, looking at community prevalence studies to unpick inequalities, integrating that climate data, looking at the movement of people across and between nations. We need to encompass a whole pathogen approach, looking at all the different bacteria across different sectors, food, sexual health, healthcare, looking at fungi, viruses, parasites, and a cross-sectoral approach is needed. And that's going to bring its own data challenges about how we integrate those all together. We need to increase the role for localized diagnostics and bespoke data development, but then retain that information within the public health system so that we can use that information for action. And that, I think, will pose considerable challenges in the future. And critically, we need to understand new antimicrobials and novel alternatives to antimicrobial usage and link up the wealth of information that might be arising from different experiences within this country and beyond. And there's a large role for increased data discovery, including citizen science approaches. So I hope that's given a good introduction to both where we've come from, where we're going, and what some of the data challenges might be in the future. Many thanks indeed for listening to this. I would encourage people to really look at the EPSRC report just to get a wealth of further information. And lastly, this is none of my own data. This is all due to colleagues in both the UK Health Security Agency, Department of Health team particularly, who developed the National Action Plan. I highlight some key colleagues here within our own organisation and beyond with our health protection research units. And finally, thank for funding for EPSRC for the Digital Health Hub grant. Many thanks indeed.